Today, on Derm School, let's look at a common pigmentary disorder known as vitiligo. This is the outline of what we're looking at today: introduction, pathogenesis, clinical manifestation, investigations, as well as management. Vitiligo affects 1% of the worldwide population. Risk factors include thyroid disease, diabetes mellitus, as well as alopecia areata. There are three theories in terms of pathogenesis. One is autoimmune, in which selected melanocytes are destroyed by activated cytotoxic lymphocytes. Two, self-destruction, in which the melanocytes are destroyed by toxic substances formed by normal melanin biosynthesis. And lastly, neurogenic, in which it is postulated to be due to the interaction of melanocytes and nerve cells. And this is commonly thought to be in segmental vitiligo. Precipitating factors include physical trauma, known as Kertner phenomenon, illness, emotional stress, occupational exposure to phenolic compounds, as well as sunburn. The skin lesions are often presenting as macules, ranging from 5 millimeters to patches 5 centimeters or more. They are often pale white and sharply marginated, and with progress, you get gradual enlargement of old macules or development of new ones. Often you see convex margins. Trichome vitiligo is when you get three colors: white, light brown, and dark brown, and they reflect different stages in evolution. Pigmentation around the hair follicles can be seen in the white macules. It is either due to residual pigmentation or return of pigmentation. This is a picture of a patient with vitiligo. In terms of distribution, it can be focal, in which you get one or several macules in a single site; generalized, which is widespread and usually symmetrical, affecting the areas around the eyes, mouth, digits, elbows, knees, lower back, and genitals. You can also have a lip tip pattern, which affects the skin around the mouth, distal fingers, and toes, with or without involvement of the lips, nipples, genitalia, and the arms. Vitiligo universalis is where you get extensive generalized vitiligo, while segmental vitiligo is when you have involvement of one unilateral region. Associated cutaneous findings are white or prematurely gray hair. Poliosis is a term that refers to circumscribed areas of white hair. You can also have alopecia areata, halo nevi, photoaging, and solar keratosis. However, squamous cell carcinomas are very rare. In terms of general examinations, think about other organ associations such as thyroid disease, Hashimoto thyroiditis or Graves' disease, diabetes mellitus, pernicious anemia, Addison's disease, multiple endocrinopathy syndrome, chorea retinitis or iritis, as well as the Vogt-Koyanagi-Harada syndrome, in which the patients have vitiligo, plus poliosis, plus uveitis, plus dysacosis, and alopecia areata. Wood slam examination can be used to identify lesions in very light skin, and skin biopsy may be required in very difficult cases. Electron microscopy can also be used, and you also have to remember to rule out associated endocrine or autoimmune diseases. For managements, patients should use sunscreens, and they can consider cosmetic cover-up. For localized macules, treatment options include topical glucocorticoids, topical calcineurin inhibitors, which may be combined with phototherapy using ultraviolet B or excimer laser, topical calcipotriol, topical JAK inhibitor such as ruxolitinib for non-segmental vitiligo involving less than 10% of body surface area, topical PUVA, which is phototherapy, and excimer laser 308 nanometer for the face. For generalized vitiligo, you may treat the patient with phototherapy or systemic treatment options, including systemic steroids given in the form of a mini pulse, methotrexate, cyclosporine, mycophenolate mofetil, minocycline, or subcutaneous alpha melanocyte. Surgery can only be offered in patients with stable and segmental vitiligo, and examples are non-cultured melanocyte keratinocyte cell suspension transplantation, mini grafting, blister grafts, split skin grafting, as well as cultured autografts of melanocytes. For patients with very extensive disease, you can consider depigmentation. This is using monobenzyl ether of hydroquinone 20% MEH cream. However, for smaller areas, you can consider using cryotherapy or laser if you want to depigment. And so that's all about vitiligo, and thank you, and see you again in the next installment of Derm School. Goodbye.